However, this decline in progesterone occurs at a more rapid pace than the fall in estrogen, leading to more estrogen than progesterone and untimely giving rise to seizures. Okay, I've stopped presenting, okay? Yeah, so however, the decline, likewise, the luteal phase, which is the phase 3 pattern, experiences an insufficient secretion of progesterone, which also causes intense seizures. With the peri-ovulatory phase, which is the third phase, there is an increase in estrogen, which causes a worsening of seizure during ovulation. The sudden rise in estradiol or estrogen comes about as the female body gets ready for pregnancy. As a result, this accumulation of estrogen tends to trigger seizure in women with epilepsy, since its proconvulsant property excites neural activity in the brain. So in summary, the complex interaction between sexual hormones and epilepsy brain activity have recently been reviewed. In general, the menstrual phases, I see Whitney doing something. So I had just explained about the catamenial seizures. So Whitney, you'll just scroll down up to the summary. Yes. So the complex interaction between these sexual hormones and the epileptic brain activity have been reviewed in general, but estrogens are mainly regarded as proconvulsants, while progesterone is a convulsant effect. This is also illustrated by the phenomenon of the catamenial epilepsy, that is, epilepsy seizures that occur predominantly in certain phases of the menstrual cycle. So the whole story here is about two hormones. Progesterone reduces the chances of having seizures. Estrogen increases the chances of having seizures. So during this period, you'll find that women with epilepsy will have more estrogen within their system, and this will lead to an increase in seizure episodes. So that was a short explanation on how catamenial seizures occur. It is just a relationship between the hormones and the seizure activities. So from there, we go to the life stages. So life stages, we are basically still talking about the hormones, but we are now focusing on family planning. We are also focusing on pregnancy and everything that happens within that stage. So approximately 50% of pregnancies in women with epilepsy will occur unplanned. So this is worrying given the increased occurrence of obstetrical complication in women with epilepsy, including the risk of seizures and their possible consequences for both the mother and the unborn child. Hormonal contraception is usually regarded bidirectional drug interaction with several anti-epileptic drugs. These interactions may lead to loss of seizure control or contraceptive failure. Further concerns are loss of bone mineral density and increased seizure activity due to the hormonal effects. Many physicians lack sufficient knowledge regarding these issues, and most women with epilepsy have never received adequate counseling. Whitney? Yeah, so we get to the family planning part. Now, in family planning, epilepsy is one of the most frequent neurological diseases. Women with epilepsy, like healthy women, use different kinds of contraceptive methods. That is, contraceptives, intrauterine devices, barrier methods, or combinations of both. Hormonal contraceptives will include combined oral contraceptives, progestin-only pills, intramuscular injections, subdermal implants, skin patches, hormone-releasing intrauterine devices, and vaginal rings. However, most women with epilepsy also use anti-epileptic medications. Many of these drugs will interact with hormonal contraceptives, which may lead to contraceptive failure. or impaired seizure control. Whitney? So either of these complications may have serious social, psychological, professional, and economic consequences. So, additionally, many anti-epileptic medications pose teratogenic potential and may exert a negative impact on cognitive and psychological skills of children exposed to anti-epilepsy disease drugs in the uterus. Yeah, so basically, epilepsy decides to use a family planning method. It has to either work because any failure on its working will affect these people either socially, they will not feel comfortable. Some will not be able to go to work because of their interfered work plan. Some will have challenges with finances. So it affects the holistic care for a person with epilepsy. That is why it is very important to have a discussion with your health provider before deciding on which type of family planning you'll work with. And you'll have to put into consideration the type of anti-seizure medication you're using, so that you decide on the appropriate type of the. Given the above, it is deeply concerning that 50% of all pregnancy among women, this is about occur unintended. So most persons with, most women with epilepsy will get pregnant and they are not aware that the pregnancy is even there. They only realize about it later. Most women will realize that they are pregnant at about 2 months. The clinical one is that are not usually prescribed during pregnancy, and if they are not aware, they might put the fetus at risk, and they might also put their lives at risk. I don't think, Whitney, you're following me. You're lost. Most women with epilepsy do not receive necessary information. A 2015 survey found that below 70% of women receive contraceptive counseling. So it is important that when we are treating women with epilepsy, we pass on seizure control, and sometimes we forget to talk to them about the choice of family planning, or even the planning of how to get pregnant or how not to get pregnant. Even when sometimes when this information is provided, you'll find that women with epilepsy might not recall the information they were given. So you have to keep on repeating the conversation most of the time that they come, so that it is within their scope. Anytime they want to make a decision, that argument might always pop up. Because if you don't keep on repeating that conversation, they might forget, and they'll end up into a situation where most of them are comfortable with. Question room, comfortable and assured on the choice that she has made. So the next part is about epilepsy and anti-epilepsy medication. This will be in effect to the female fertility and pregnancy. So many women with epilepsy will have normal sex lives and normal pregnancy. They, in general, might have lower fertility rates than healthy women, but not to all. So most of them will have normal fertility. Oligo or amenorrhea occur more frequently in women with epilepsy than in women without epilepsy. So in the oligoamenorrhea basically means some of them will have excessive bleeding. Some of them will have bleeding that will not be as consistent as they expect. Some of them will only experience spotting. Spotting is where you only see some dots of blood, but the whole flow does not take place. So this might affect persons with epilepsy, women with epilepsy on medication. So you need to give them a solution on such conditions. So this is more common on anti-epileptic polytherapy than with monotherapy, which suggests a casual role in anti-seizure medication. So you'll find that a patient on, let's say, one type of anti-seizure medication will not experience such complications as metrorrhagia. Metrorrhagia basically means overbleeding. Amenorrhea, loss of the bleeding is not coming, and irregular menstrual bleedings. So that is why we always focus more on monotherapy. Don't put patients on so many anti-seizure medications. This might lead to other complications like the ones that have been mentioned there. However, there is available data that suggests that seizure and epileptic discharges, especially from the temporal lobe epilepsy, may negatively affect ovarian function and ovulation through disturbance in the hypothalamic and pituitary axis. So these are the axes within the brain that control electrical discharges within the brain. It is also well established that enzymes, including there are enzyme-inducing anti-seizure medications which may increase sex hormone binding globulin, and this in turn might induce the metabolism of sex steroid hormones, and thus reducing the serum concentration of free and total sex hormone. Is one of the most frequently used anti-epilepsy. Basically, what means is the interference of the normal flow of the menstrual period. So valproate has been found to interfere with this whole process, and the underlying mechanism are not completely understood. But an interaction of valproate with sex steroid synthesis and metabolism in the ovary is usually presumed. So women with epilepsy also have a higher risk for complications during pregnancy and delivery. We have situations like hypertension. They are more prone to hypertension. They are more prone to preeclampsia. They are more prone to bleeding and preterm birth or small for gestational age. Small for gestational age are children born before their delivery time. We also have spinal deformities, and here we are talking talking about things like spina bifida. We also have facial bone deformities. We have cleft palate. We also have the frequency of sick. Current evidence suggests that both epilepsy itself, as well as drug treatment with anti-epilepsy drugs, may affect female fertility and cause complications during pregnancy and delivery. These findings underline the importance of pregnancy planning, which includes contraceptions. So the reason why we need to have this serious conversation is because, one, a woman with epilepsy might decide not to have kids. A woman with epilepsy might decide to have kids. So in all these scenarios, they have to be aware so that they make a well-informed decision on whether they have kids or they don't want. We have a situation of valproate. In valproate, we usually don't give it to women in childbearing age, but a patient will come with a situation where seizures are only responding to valproate. So what do you do in that situation? You don't just give it. You have to explain to them what it does. You have to make them aware so that they are the ones to make the decision whether they are using the medication or they are not using. Once they decide to use the medication, you don't just start them on the medication. They have to sign a consent form to make sure that they understand whatever they are saying. They understand the risk that is involved with the medication that they've chosen to use, and they are completely aware in that the decision that they've made to use the medication is out of cell conformation, and they understand all the risks that are involved. So basically, that is what that part means. So from there, we go to what anti-seizure medication do to hormonal contraceptives. Why do we always advise women with epilepsy to use non-hormonal contraceptives? Because we understand that anti-seizure medications mostly interact with hormonal contraceptives, and you might find situations where the hormonal contraception did not work because a patient was using the specific type of hormonal contraception, but still using anti-seizure medication that were countering the effects of the hormonal contraception. So we have first generation anti-seizure medications. These are phenytoin, phenobarbital, carbamazepine. Those are the most common within our market. And we also have second generation anti-seizure medication. Most of them are not within our market, so I'll not mention them. So we have more or less pronounced enzyme-inducing effects. So these medications, phenytoin, phenobarbital, and carbamazepine specifically, will have an enzyme-inducing effect. They may induce either cytochrome, which is P450 enzymes, or uranidine diphosphate gets there. So the contraceptive failure provoked by enzyme-inducing anti-seizure medication is common and may affect both the oral and non-oral hormonal contraceptives. We have the injectable hormonal contraceptives, and we also have the oral contraceptive. The estrogen compound used in combined hormonal contraceptives usually is ethinyl estradiol, which is EE, which has been used for decades. This one is mostly affected by anti-seizure medication. So you need to really have that conversation when a patient is on phenytoin, a patient is on phenobarbital, or a patient is on carbamazepine. You need to explain to them what might happen if they get the injectable hormonal contraception, or if they are using the oral contraception. They might need to change the choice of the contraception, or they might need to use a combined form of contraception, which is usually you are using hormonal contraception and you are also using the barrier method. Barrier method are things like the condoms. We have both male and female. Yeah. So in general, yes. Kiserem, was that a question?
No, I'm sorry, it was not a question.
Okay. So in general, their metabolism is inducible like that of the ethyl estradiol. Thus, their contraceptive effect may fail when they are co-administered with carbamazepine or other enzyme-inducing anti-seizure medication. The enzyme-inducing ones I've mentioned, the three: phenytoin, phenobarb, and carbamazepine. Examples of these include the oral levonorgestrel, oral norethindrone, and the subdermal etonogestrel implant. The subdermal etonogestrel implant is the one that is put under the skin, usually on the upper limb. So you'll find some women with the family planning that is usually put on the arm. So that is the subdermal etonogestrel. Then the oral, we have Femiplan. We have so many brands in the market. We have the one that is taken for 21 days. Interaction potential of depometosterone acetate. This is 3 months. However, if a specialist has not, the interaction potential of depo-metollogestrel acetate, which is the Depo-Provera that we are used to. Seizure medication has been found to induce the metabolism of one specific progestin. It appears reasonable to assume that other progestin may be affected as well. So if you find an effect on one type of progestin, you assume that other types might also be affected, so you might need to be careful when administering them. So on the other hand, there are many different hormonal contraceptive preparations available. So they may contain not only different hormones, but also different doses of the etheroestradiol and different doses of the same progestin. The conversions drawn from one study investigating one hormonal contraceptive preparation may not necessarily apply to the other hormonal contraceptive preparation even if the available data suggests that an interaction is unlikely to occur in a specific hormonal contraceptive and anti-seizure medication combination. The attending physician and the patient will contraceptive failure. So in summary, in patients taking anti-seizure medications that interact with the hormonal contraceptives, which are the drugs are the phenytoins, phenobab, and carbamazepine. I'm only mentioning the three because they are the ones that are mostly within our market, and other form of contraception, e.g. the barrier method, intrauterine device, or a combination of both, or alternatively, discuss with the patient's neurologist if switching to an enzyme-inducing anti-epilepsy drug is possible. So you can, as I mentioned up there, you might decide to use barrier method. You might decide to use the intrauterine device. An example is the copper T, or you might decide to use a combination of both, either both the barrier method plus the other invasive method. So in patients taking lamotrigine, avoid hormonal contraceptives that contain the EEs. These are combined oral contraceptives, some of you call them Femiplan, the patch, or the vaginal ring. Or alternatively, omit the EE-free week, extend the cycle regimen. So inform and educate the patient well on available contraceptive methods and their strengths and weaknesses, frequency and possible consequences of the non-adherence, possible drug interaction between anti-seizure, pre and postnatal adverse effects of epilepsy medication, seizure, size and nature of the teratogenic risks of the anti-seizure medication. The teratogenic risk here are the spina bifida and the facial bone injuries. We talked about the cleft palate. So those are the teratogenic risks. These are basically risks that affect the fetus when still in the mother's womb, and a possible negative cognitive effects of the anti-seizure medication, because you'll find that some of these children will be born and they were exposed to medications like the valproate. You'll find that their cognitive capacity becomes low because of that exposure. Yeah, so basically have a real conversation about the choice of medication and hormonal contraception that you need, because it mostly decides and affects the patient's outcome. We usually advocate for long-active contraceptive measures, which are the intrauterine devices and implants, to avoid risks of missed pills. So most of our patients are usually put on the intrauterine device. An example is the copper T or the implant. Yeah. If the patient prefers oral contraception, suggest to use a smartphone, which is a pill reminder, digital tablet dispenser, or other measures to minimize the number. We are now getting to the bone aspect of the anti-seizure medication, and in this, it has long been known that patients taking enzyme-inducing anti-epilepsy medication, which are phenytoin, phenobab, and carbamazepine, are at a significantly higher risk of developing osteoporosis, and also have been associated. The hormonal contraception has also been associated with that is decreased bone mineral density and increased risk of fracture, particularly when used for more than 2 years. Regarding the effect of other contraceptives, progesterone or EE recent meta-analysis conclude that data still are conflicting despite a large number of published studies. Some, but not all studies show that EE may reduce bone mineral issue, most importantly, the effect of hormonal contraception, especially the depot and enzyme-inducing anti-epilepsy drugs on bone mineral density, and may add up, which is another reason to avoid this problematic combination. Yeah, so basically that is all about contraception, and all we are saying is that have a candid conversation with your patients before you decide on putting them on a specific type of medication, because the type of medication that you give and the type of hormonal or family planning that they will choose will affect their response to both the seizures and to they were using the contraception to not get pregnant. And when a patient uses that contraception and then ends up pregnant, it really affects them socially, psychologically, and their mental status is usually okay. We have situations where patients are having children and they were not ready to have children, not because it happened, but it's because they were not well informed on the choices of family planning that they are supposed to use. And sometimes they get pregnant while on medications that are contraindicated during pregnancy. And this leads to situations where children are born with birth defects. And these birth defects are usually not so okay. We even have kids who are born with cognitive defects. They cannot really assimilate within the society. And most of this you'll find happening as a result of not having a conversation. It is as simple as having a candid conversation with your patient to first of all, to make you understand what they want. After understanding what they want, you now inform them of ways of achieving what they want. So basically, that is what we are talking about, to ensure that our patients, especially women with epilepsy, are physically okay, meaning that their seizure is controlled, are mentally okay, meaning that they don't have unnecessary stress and depression because of things that did not go the way they wanted them to happen, and because of not being informed in the right way. So basically, that is what we are communicating about, and that marks the end of my presentation. The recommendations are there, but I'll not go through them. I will just I will share the presentation so that if anything was not clear, you might go through the presentation and understand it better. Thank you very much.
To hear from the horse's mouth. This is Sabrina herself, who is a patient and also who is a medical person who does is an orthopedic trauma technician, graduating from KMTC Machakos. She has a lot to tell us today as a woman with epilepsy. Welcome, Sabrina. Feel at home. Please share your story. Thank you.
Thank you so much, Teddy. Thank you so much, Doc. My name is Mary Sabrina. I'm a patient in Rirota, and I'm excited once again to share my journey. I'm an orthopedic doctor. I graduated from KMTC back in 2023, and yes, so back in 2003 is when I was diagnosed with epilepsy. I was put into drugs, fentanyl, and yeah, I took the drugs until now, whereby they were changed to fentanyl and carbamazepine. I take fentanyl, just a minute, 100 grams, and carbamazepine, I take 200 grams. And my journey has not been easy. It has not been easy. And living with epilepsy has taught me a lot of things. I have lost friends. I have lost family members, simply because I was told that in one of my relatives told me that on their side they don't have disability people, and that hurt me a lot, and it has been like that. I have lost jobs, and I wouldn't wish epilepsy on someone, but I'm thankful I went to KAWE and I was introduced to proper medication, whereby I have been taking them. Not so well again, because at times I feel like this is too much. I have to admit, this is too much, and I miss my drugs, and then again the seizures start happening, and they are too bad, because once I get them, I get to pee on myself, and I lose control of my bladder, and
Sabrina, we are with you. We are supporting you. You know we are here.
yes,
Be strong. You are a woman. It's your day. Go
yes, thank you
on.
so much. And until recently, I felt like I should stop lying and accept that, yeah, this is epilepsy, and if I want to manage it, I have to take the drugs, which I take. But then again, carbamazepine has done me bad, because I feel dizzy once I take carbamazepine. I don't know if it happens to any of us who take the drugs, but I'm still taking the drugs, as much as the side effects are there. So another thing that I feel about epilepsy, I having epilepsy, given that I was diagnosed in 2003, those are almost 25 years, 24, and rejection here and there, which is something that I didn't expect from my close friends and my workmates, my bosses, stress here and there. I am strong. That's what I can say. And I'm in this journey. I'm not stopping because I have come to accept it. Yes. Another thing with me is that I get stressed up a lot, and it's not good. I know, but given that I have gone to a medical school, I should be working somewhere, things are not giving in. So once I think about that, again, the attacks get to me as much as I'm taking the drugs as prescribed. So it has not been easy, to be honest. And
We hear you. Tell us when you're ready to stop, but we are with you all the way, Sabrina. And today is your day, and we are so happy that you're talking about it. And that's the reason we are here, right? Right, people? Everybody wave to Sabrina. Well done. Look at that. Well done. Well done. Oh, wow. Oh, wow. Oh, wow.
thank thank
Well done.
Thank you, Teddy. Thank you. And before I begin, Mary, what could I say to you? I'm sorry that you have had a challenging journey with epilepsy, but I want to tell you there is hope, and that you have options. Even with the medication, there are ways that symptoms can be managed. So please look for me after. Thank you, Whitney. Thank you for putting the presentation up, and holistic wellness. And within the theme of Empower Her and Women and Epilepsy, kindly proceed, Whitney. Thank you. So why does this matter? And this is the foundation of the few thoughts that I'll share. The reason this is important is because of the hidden cost, especially for women, because often in high-performing spaces, exhaustion is normalized as a badge of honor. And we often find ourselves in environments where if you're not burnt out, you're not working. Yeah, I don't know if any of you have experienced that. Or if you say, or if you communicate, you need some time off, or you need a break, or you need to rest, then that is seen as weakness. Yeah, and because it's the Women's Day is coming up and it's the Women's Month, although I know we have some gentlemen on this call, this message is mostly for women, and because many women are, and also I feel like we have been socialized to prioritize other people's needs while we silently sacrifice our own, this needs to change. And I believe there is hope, even if we start with small steps. But I would love to get to a space where women feel equal and act equal, even though we are created differently, to our male colleagues. And what is the path forward? True thriving requires a powerful integration of three essential: speak your truth. Two is to create boundaries. And I want to emphasize is to integrate your voice and the boundaries so that you can honor your whole self. Next, Whitney. So what is self-advocacy? Because that's one half of my short presentation today. Self-advocacy is the courageous act of recognizing your inside worth, the worth that you were born with, and continuously taking intentional steps to honor that worth. Anyone can learn courage. Yeah, it's not the preserve of a few. So if you decide to be self-advocating, and I encourage that all of us do, we can learn how to do that. And what does self-advocacy involve? One is understanding, and understanding comes with self-awareness, where you take some time and reflect, and you get to know what are your needs, what are your rights, and what are your values deeply. The second is to communicate. Once you know, you communicate, you share. And when you share, you express all your needs, rights, and values clearly, but also respectfully. The third is around decision-making, so that your decisions are aligned with your values. Your decisions are aligned with your needs, and your decisions are aligned with your rights. And lastly is protecting, and that is where boundaries comes in. Yeah, you safeguard your well-being through taking intentional steps. So advocacy, in summary, is not about being loud. It's about being true to yourself once you take a little time to know who you are. Next. All right. All right, great. Okay, so bear in mind, please ask for options. When you're self-aware, you know your needs, your rights. Thank you, Whitney. Yes. You need to now develop the courage to ask for options. You have to accept just one option. I encourage all of us to ask for, is there any other way of doing this? Is there an alternative path that I can follow? The second is to request for clarity. The professional research consultant, that's really my job, to ask questions on behalf of my clients. And like I was saying at the beginning, a lot of this is tailored for women. It's fine to just ask questions and get clarity, and to your time. Yeah, if you need time, take your time. Never feel rushed. There's always more time than we imagine. And the last is to set boundaries. And no is a complete sentence. Yeah, ladies and gentlemen, it's a complete sentence. So if it will take too much of your time, if it will add on to things you're already processing or going through, you can just say no. And even you can say not now, perhaps another time. All right. Each phrase is a declaration of self-respect. Kindly move on, Whitney. Thank you, Teddy. All right, so now we've talked about ourselves. I'd like to invite us to think about community. There's power in community and there's power in collective advocacy. So how can we as women and even gentlemen ride on the power of community? One is to amplify the quieter voices. There'll always be people around us who maybe are better at communicating in writing. So when it's speaking, they're not always comfortable. I invite you to speak on their behalf, to listen keenly and hear what they're trying to communicate. So use your platforms. All of us have platforms, whether we know it or not. And when you have a seat at the table, pull up a chair for the person behind you who may not have access to that same seat. The other thing we can do is recommend other women. So be a connector, yeah? Share opportunities that you come across and actively support talented women in your network. And talent, we've just not discovered them. So our talents, try out different things that you feel connect other women around you transparently, because knowledge is indeed power. And together we rise. Next, Whitney. I'm ready for the next slide. Thank you, Whitney. I'll try and rush through this section, which is around holistic wellness. So the first half was all about speaking for yourself and getting to know more about yourself. And this section is about holistic wellness. So by definition, it's an integrated approach to well-being, and it honors the full spectrum of human experience. So when you're thinking of well-being, don't just think of, I'm not sick, so I must be well. It includes very many dimensions of who we are. So it's not just physical, it's social and professional and spiritual and emotional and mental, yeah? And so when we consider all these aspects of ourselves, we are thinking about holistic wellness. And when we act on these different aspects of ourselves, we move from functioning, which is just doing enough to get through the day, to flourishing, which is where we are truly thriving. Next slide, Whitney. The other point I should make is that true wellness requires attention to all those aspects I've mentioned. Yeah, that's when we are really talking about. Thanks, Teddy. I'll wait. So what are the dimensions of wellness? I already touched on them. And here we'll get into just a little more detail quickly. There's physical, emotional, mental, social, spiritual, and professional. So physical, I believe we all know. And what can we do to take better care of ourselves, whether or not we're living with epilepsy or whatever conditions we may or may not be living with? One is to have enough hours of sleep. 2 is to eat nourishing meals. And 3 is for us to move. When we exercise, we release hormones into our bodies, and these make us feel joy, feel excitement. I don't know if you've ever done, even if it's just 10, 15 minutes of exercise, and you shower and you feel so good about yourself. It doesn't, it's not about the duration of the exercise, it's just about moving. The second is emotional. So we need to be honoring of our feelings as valid messengers to ourselves. So when we are processing feelings, whether or not we are emotionally regulated, when we experience feelings like self-compassion or care or just the different kinds of feelings, that is taking care of our emotional wellness. The third is mental, and some of the examples of caring for our mind is to seek mental clarity, to build resilience, and also just to keep learning. Some of the other ways we can do this are to take part in brain teasers or jigsaw puzzles. Yeah, I've heard even knitting and crocheting is good for the mind. So even things that we may consider simple are actually helpful for us. I'll move to social, which is all about nurturing the connections and the relationships that uplift us. Yeah, so we need to seek supportive relationships. We need to develop healthy communication skills, and we need to belong to communities. No man or woman is an island. So find a community that supports you. Spiritually, we need to connect with meaning and inner purpose. And so when we find out what our purpose is, we need to do activities that align with that purpose spiritually. Whenever we're looking for meaning, whenever we're feeling grounded, and if we are people of faith, whatever faith, we can meditate, we can pray. All these activities improve our spiritual wellness. And lastly, for professional self-care, examples include work-life balance. If you don't have to do something, you can always delegate to someone else. And as much as possible, to try and engage in work that aligns with our values. Next slide. And this section is about proactive wellness. So we don't need to be waiting to get sick and then, ask for time off. We can cultivate a habit of resting before we are completely exhausted. We can think through boundaries for ourselves before we end up resenting people for asking us to do things that we really didn't want to do. And we can also seek support before we enter into a crisis that could have been avoided if we had sought support beforehand. And how can we do some of these things? It's small daily deposits and examples are just a few minutes in the morning or the evening of reflecting how our day has gone or what we're hoping how the day will go. We can have, if we're not able to have all our meals well balanced, if we just have one meal a day that contains the 3 food groups, that's being proactive. We can take a brief walk in nature. And we can say no to one thing that is asked of us. Next slide. What is the connection? And as I finalize my short presentation, advocacy protects. When we speak out and we're self-aware, self-advocacy is the guardian of our wellness. And wellness sustains. If we're taking care of ourselves in all these different aspects, these activities help us to feel well, to feel good about ourselves, and to find spaces where we can speak up. And when we are well, we will have energy, we will have clarity, and we'll be able to build the courage to speak up and to stand firm. So speaking your truth, self-advocacy, and being well and sustaining your wellness leads to sustainable impact. Last two slides. So self-advocacy is how we use our voice, and holistic wellness is how we protect our whole selves. And when we practice both, we don't end up functioning, just getting through the day. I believe we can truly thrive, which makes us flourish. I would, as a last point, I'd like to direct those of us who are living with epilepsy to some resources. If we can move. One of them, I believe, is here on the call, Kiserem Foundation. And they are located at Leah's Plaza, opposite Mwihoko Primary School. I've included their website and what they do. Shine Epilepsy, not sure if you're here, also provide epilepsy support, and Youth on the Move. As the name suggests, it's largely for young people, and they are located in Nairobi West, and I've included their website. So yes, feel free to get in touch. I've included my email address and my contacts, and thank you so much for your time. Back to you, Teddy.
Thank you so much, Sharon, for your presentation. It was amazing. I do have a question for Nicholas regarding epileptic women. Are they more likely to have a higher risk pregnancy? And if there are higher risks, what are they?
Thank you very much for your question, Annie. Basically, women with epilepsy have normal pregnancies just like any other members of the community. But now the issue of pregnancies that don't go so well comes when the choice of medication was not made properly during reviews. So we are talking about situations where patients are put on medications that are contraindicated in pregnancy. We are talking about medications like sodium valproate, which are contraindicated in pregnancy. Some of them will use the sodium valproate while using the family plannings, hoping that they will not get pregnant. Then accidentally they find themselves pregnant. So what the main question should be, what are the precautions that should be done during that situation? So in case a patient finds herself pregnant, And in on such medications, the best thing is to go to your consultant, get reviewed, get the medication either tapered out or replaced, and the pregnancy can be saved. It's not that automatically you get pregnant and you are on sodium valproate, the child or the fetus will be affected. If an intervention is done early, the situation can be saved. So the conditions that we are talking about here are mostly spina bifida and cleft palate. Those are the most common defects that occur in women with epilepsy getting pregnant, mostly when on valproate-based medications. So basically, in general, women with epilepsy are safe and they can get pregnant and get children who are okay and normal. But in situations where they are on medications which are putting them at a risk, it is important to have that conversation and to ensure that the safety of both the fetus and the mother is confirmed early. I also talked about conditions like hypertension, preeclampsia during pregnancy. This will only occur and mostly occur when the seizures are not well controlled. But once you are on medications and your seizures are well controlled, most probably their pregnancies are usually safe and they carry on to the last month until delivery in a good environment. The most important thing is communication. Communicate with the clinic where you are getting epilepsy care and communicate with the clinic where you are getting antenatal care. So these two clinics should have a clear communication and a clear management plan to ensure that both the mother and the fetus are okay. So it is a collaboratory thing. Thank you.
Thank you, Nicholas. That was really clear and helpful.
Thank you so much. My question is to Dr. Nicholas. You talked about osteoporosis and phentoin and carbamazepam can make people who are taking carbamazepine and phentoin are at a higher risk. So I was just wondering, is it, am I affected? Kwa sababu I have been taking phentoin for the longest time and carbamazepine. So please talk about that. Thank you.
Yeah.
Nicholas,
Hello.
that question is directed to you. Thank you.
Yes. So, Sabrina, I understand I mentioned carbamazepine as one of the enzyme-inducing medication that people use, and it causes there's a risk of developing osteoporosis. That is true, but you see, it is the timeline given is a span of 2 years. So after 2 years, you'll notice that most of our medication, when we put you on long term, we will add folic acid at some point, not throughout. And at some point, we usually also add a supplement, mostly the calcium supplement. And we advise also on taking bone soup. The whole idea here about bone soup, calcium supplement, and folic acid is usually to help replenish the calcium deposits within your system so that at least the osteoporosis does not affect you. So we have situations where we put you on other medications that will support what the drug might take down. And we usually expect that after some years, your seizures have gone down, then we will start tapering down the medication and hence ensure that your bones are also safe as much as we are doing seizure control. So sometimes you'll find yourself on calcium supplements. And before we go to the supplements, by the way, we usually advised on healthy feeding, which is usually getting that calcium in your system through what you eat. The supplements only come as the last alternative. And you'll notice that when we get to the supplement point is where we have a situation where you are now having fractures and all that. But mostly we will focus you on the diet, the calcium improving diets.
Thank you, Nicholas. I think, Mary, you have been answered your question. Thank you so much. Thank you, Daktari. We would like to hear from Frederick Beuchi. Please talk to us so we can see your hand is up.
I'm not sure if it is me.
Oh, sorry.
Okay. Thank you so much for the opportunity. I think my question has also been addressed by Mary. My name is Frederick Beuchi. I actually wanted to ask this question on behalf of my wife, who is not able to join us here today. But recently, we were blessed with a baby boy, and my wife is actively living with epilepsy, and she's on medication. And we have been cautioned about her breastfeeding the baby. And the doctors are still not very clear whether it's because of the medicine that she uses, because what we experienced when the baby was born, the baby was not very active, and he was a lot of the times very sleepy and not very active, and they alluded that to either the medicine that my wife was using, and because of that, they said she should restrain a bit from breastfeeding the baby. So I don't know, Daktari, maybe you can, because we are yet to really get a good explanation of why. Are there medicines that are extracted through either breast milk that can either have such effects on the baby? Because I think we all know the importance of, the breastfeeding for the baby. So maybe you can help us with that as well. Thank you.
Nicholas, this question is, I think, to you. But before we say anything, we would like to congratulate Beuchi on the birth of your son. Welcome, Junior.
Asante.
Okay, thank you very much, Fred Beuchi. First of all, congratulations for getting a son. It's a great milestone, and we appreciate you for that. So, on your question on breastfeeding, your child, your wife has been advised to tone down on breastfeeding. I'm assuming that he's not been told to stop it completely. Yeah, the reason being is that there is usually that assumption that the medication will pass through the breast milk, but the chances of it passing through breast milk are really so. Usually encourage breastfeed, and children don't for not breastfeeding, because that breast milk is more important to the child than any other external feeds. So in such a situation, I would advise you to continue breastfeeding as you monitor the response of the fetus. So it is a situation where very few medication pass through breast milk. Some of them will pass, but the concentration in the breast milk is so low that it doesn't really cause severe harm to the child. So my advice would be breastfeed, but moderate as you observe on the child's response. So the child response is what will guide you on whether to tone it down or to continue. But my advice would be don't stop breastfeeding, because it is the most important meal for that child right now.
Okay, thank you so much.
Thank you, Daktari. We appreciate.